Welcome to This Explainer. Today, we're stepping right onto a battlefield. But, this isn't a war fought with tanks or artillery. It's a high-stakes, microscopic war reaching right inside the human body. We're going to dive into the fascinating, complex, and honestly, sometimes incredibly dangerous biology of urinary tract infections, or UTIs. If you've ever wondered exactly how a tiny, microscopic invader manages to breach some of the human body's absolute toughest defenses, well, you're in exactly the right place. Let's get into it.
To really understand this war, we got to look at the primary aggressor. Take a look at this quote. We all have an intimate relationship with E. coli. Just as human relationships can be nurturing, then suddenly turn dark and ugly, so can our association with our little bacterial companion. It's so true. We all have this lifelong relationship with E. coli. It actually takes up residence inside our bowels from the time we're just 2 days old, and it stays with us for life. Most of the time, it's a totally peaceful, even helpful coexistence. But biology is incredibly dynamic. Depending on the specific genes this organism picks up and the current state of our immune system, that nurturing relationship can suddenly turn dark.
So that brings us to the absolutely crucial question. How does a lifelong, peaceful companion suddenly become a deadly invader? To figure that out, we really need to shift our perspective. We have to look at the urinary tract not just as a standard piece of human anatomy, but as an incredibly hostile, heavily fortified environment. It literally forces bacteria to either adapt aggressively or just be utterly destroyed. Let's gear up and examine the front lines.
Section 1. The border defenses. The body's hostile terrain.
Now, unlike the bowel where nutrients are plentiful, the urinary tract is a completely different world. It's normally totally sterile and for very good reason. Nutrients are so incredibly scarce there that bacteria actually have to synthesize their own amino acids just to survive. But starvation is really just the first hurdle. Obstacle number 1 is the sheer physical force of urine flow, micturition, which acts like a literal tidal wave to flush away anything that isn't bolted down. If bacteria do try to grab on, the kidney deploys the TAM horsefall protein, or THP, to intercept them. Meanwhile, you've got these cellular patrols made up of white blood cells called neutrophils actively hunting. They release lactoferrin, which literally steals the trace amounts of iron bacteria need to live, all while blasting them with cell membrane disrupting peptides called defensins. But honestly, my favorite defense is our own resident flora, specifically lactobacillus. These helpful bacteria produce surfactants to straight up destroy rival E. coli. And, amazingly, they secrete proteins that downregulate our own immune system. They're essentially telling our body, hey, hold your fire, we've got this, which maintains a peaceful symbiotic barrier.
Okay, so anatomy also plays a massive role on this battlefield. When we compare male and female defenses, men just have a distinct structural advantage. The male urethra is about 20 centimeters, or 8 inches long. Compare that to just 4 centimeters, or 1.5 inches in females. That is a much, much longer road for bacteria to climb against that flushing tide of urine. Plus, men have a prostate gland that secretes prostatic antibacterial factor, which actually uses zinc ions to actively damage bacterial invaders. Because of just these two factors, the incidence rate of UTIs in men is only about 1/30 of what it is in women.
Section 2. The bacterial arsenal. Weapons of microscopic war. Given those heavily entrenched border defenses we just talked about, you might be wondering how bacteria get through it all. Well, it turns out out of the roughly 700 recognized serotypes of E. coli, only about 10 actually possess the specialized virulence factors required to launch an invasion. And the absolute primary weapon in that arsenal? Fimbria. Think of fimbria kind of like a rigid flagpole sticking right out of the bacterium, with a tiny floppy hook or flag at the very end, just desperately waving around to find a compatible cellular receptor. Without these tiny hair-like structures tightly anchoring the organism to the epithelial cells of our urinary tract, the bacterial invaders would just get washed away by the next wave of urine. But remember that TAM horsefall protein we mentioned earlier? Here is where it really shines. THP acts exactly like a decoy flare fired from a fighter jet. It specifically latches onto a type of bacterial hook called type 1 fimbria, basically binding the bacteria up and neutralizing them before they can attach to the actual cell wall. Interestingly, this is exactly where the famous cranberry juice myth comes in. While it's definitely not a cure, cranberry juice contains high levels of quercetin. That's a flavonoid that experiments show acts just like THP, preventing E. coli from adhering to our surfaces. Pretty cool, right? Now, if the bacteria do manage to bypass those decoy flares, they initiate this brilliant localized engineering project, the biofilm. It's actually very much like the dental plaque you scrape off your teeth. It's a highly resilient scaffold built in 3 distinct layers. The bottom layer uses those fimbriae and sticky carbohydrates to anchor incredibly tightly to our cells, forming a junction that basically locks out attacking neutrophils. Then, the middle layer acts as a structural bridge. The bacteria here are literally starving themselves, in a state of reduced metabolism, just to hold the whole structure together. Meanwhile, the top layer is the active war zone. They're reproducing wildly, climbing further up the urinary tract, and shunting nutrients all the way down to keep the lower troops alive. It's a masterclass in survival.
Section 3. Bladder skirmishes versus kidney wars. The escalation. As these biofilms systematically climb higher, the entire conflict escalates. What starts as a localized skirmish can rapidly transform into a full-scale internal war, and it all depends on where the bacteria plant their flags. Let's look at the breakdown. In cystitis, that's a bladder infection, bacteria use type 1 fimbriae to target mannose proteins. Our epithelial cells fight back by releasing interleukin-8, which summons this massive swarm of neutrophils. That's what causes that localized pain and urgency. Usually, our innate immune system handles this within a week. However, in pyelonephritis, a kidney infection, bacteria deploy P. fimbriae. These are designed to specifically target the actual filtering units of our kidneys, the nephrons. To make matters even worse, these bacteria cover themselves in this gooey polysaccharide capsule, which makes it nearly impossible for our neutrophils to engulf them. The result? Severe flank pain, chills, and a very real high risk of potentially fatal sepsis. To truly wrap your head around the scale of this microscopic war, just look at this number, 7 million. That is the number of outpatient women who go to the doctor and receive a UTI diagnosis every single year in the United States alone. 7 million. And keep in mind, that doesn't even count men or patients who acquire them in hospitals via catheters. This is a massive, incredibly common battlefield.
Section 4. Diagnosis and medical counterattacks. Turning the tide. So, with a battlefield this vast, how do medical professionals actually analyze the war zone? Well, before ordering expensive multi-day urine cultures, doctors often use rapid dipstick testing, basically deploying chemical scouts. The nitrite test looks for the chemical signature of E. coli converting natural nitrates into nitrites. It's a fantastic screen, but the downside is it takes hours for bacteria to actually do this. So a fresh sample might read negative, and it completely misses some non-E. coli pathogens. On the flip side, the leukocyte esterase, or LE test, actually looks for the presence of our own troops. It detects an enzyme found in our attacking neutrophils. The pro here, it's blazing fast. Takes just 1 minute. The con? Things like vaginal infections, like trichomonas, or even certain antibiotics, can easily trigger a false positive. Section 5. The doomsday scenario, urosepsis. Now, we need to talk about what happens if our innate immune system fails, and our initial counterattacks just don't hold the line. We face the ultimate threat. When bacteria breach the kidneys and enter the general bloodstream, it becomes a system-wide doomsday scenario. The true danger here lies right in the enemy's structure. Gram-negative bacteria contain lipid A, which is an endotoxin. When they multiply in our blood, this toxin triggers a massive, totally panicked overreaction from our immune system, a cytokine storm. Our body desperately attempts to wall off the infection by forming blood clots, but it happens everywhere, all at once. This widespread clotting leads rapidly to shock, multi-organ failure, and, if left untreated, death. When a patient hits septic shock, modern hospitals do not have the luxury of waiting days for a lab culture to identify the exact enemy. They have to hit the invaders with absolutely everything they've got, immediately, just to stabilize blood pressure and stop the clotting. We call this empirical antibiotic therapy. We throw a heavy-hitting cocktail at the infection, using drugs from completely different classes, things like ceftriaxone, tobramycin, and levofloxacin. The hope is just that the invading organism is susceptible to at least one of these powerful weapons. But here is the terrifying reality we are facing today. Because we use these weapons so often, the bacteria are adapting. If an invading strain of E. coli, Proteus, or Klebsiella happens to be resistant to all the drugs in our empirical cocktail, they simply survive the onslaught. And even worse, they can pass these antibiotic-resistant genes right over to their neighboring organisms. These multi-drug-resistant superbugs don't necessarily cause more frequent infections, but they render our standard, safe treatments completely useless. By the time the lab results finally come back, showing what the bacteria are actually vulnerable to, it might just be too late for the patient. And that brings us to the most critical question of all. Our bodies have evolved absolutely incredible defenses, and modern medicine has given us powerful antibiotic artillery. But bacteria are ancient, highly adaptable survival machines, and they are actively learning to outmaneuver our very best drugs. So as superbugs continue to evolve, who will win the next microscopic war? It's literally a biological arms race happening right now inside millions of people. Thank you so much for joining me for this explainer. I really hope it gave you a profound new appreciation for the silent battles raging within us every single day. Keep learning and stay curious.